Professor Marc Raymond, nice to see you. There is a new technique, a lot of people speak about that. The name is PPAC. Can you explain to us the interest and the idea of that technique?
Thank you. Yes, of course. So PPAC is for pressurized intraperitoneal aerosol chemotherapy, and it's all about physics. What we are doing is not basically a therapy. PPAC is more a drug delivery system based on physical principles. So we take advantages of existing laws and conditions to improve the pharmacology of the administration of intraperitoneal drugs. And the two main physical principles that we are using are first the gas and the second the pressure. The gas, we didn't invent anything. It's a French physician who described about 200 years ago that gas has a homogeneous repartition within the closed space. It was Mr. Gay-Lussac. And of course, it's very interesting when you have adhesions in the abdomen to use a gas rather than liquid, because the gas will have by itself a homogeneous repartition, and these without restriction concerning adhesions. And the liquid will find the way of the lowest resistance to diffuse within the abdomen, and therefore we only reach a limited surface of the abdomen. That's something a lot of surgeons have trouble to understand, but it's just physics, and that's the reason why when you insufflate an abdomen with CO2, even in the presence of adhesion, the whole abdomen will expand and only a part of the abdomen. It's physics. The second one is pressure. So in the normal situation, the pressure within the abdomen is 0. And in the disease condition, the pressure gradient, the oncotic pressure gradient, goes towards the abdomen. That's the reason why the patient develops ascites. Moreover, the pressure of the fluid within tumor nodes is increased. So what we do, we apply pressure within the abdominal cavity, which is nothing new either, because we do it anyway during cilioscopy, laparoscopy, and these counteract the interstitial fluid pressure and increase the transport of fluids from the abdomen into the tissue. For large molecules, the transport into the tissues is convective tissue, which means it's along a pressure gradient. It's pressure driven, and therefore, of course, makes sense to distribute drugs with a large molecular weight along this artificial tumor gradient. These are the principle. Now, to apply that, you need technology, and I brought you the core element of this technology. It's a micropump. That's about the same you have in your common rail diesel engine in your car. So here you have within the pump a pressure of 20 bars. What is 20 bars? About 10 times what you have in your tires of the car, so it's a lot of pressure. And here you have a nozzle which produces a very tiny aerosol with the drugs. The drug is pushed into the pump along this high pressure line from a conventional injector used in vascular surgery, in cardiology or in radiology. And at the tip of the instrument, the pressure is the normal pressure in the abdomen, meaning 12 mm mercury, like usual in a laparoscopy. So this does not increase the pressure within the abdomen.
Okay, so not a new idea, but a new device with an old idea to increase the penetrance of the drug inside the peritoneum under laparoscopy. Yeah?
That's correct.
And did you have some results? Did you start? How many times did you start, and how many results did you have, you and other teams?
So I started 15 years ago with DID. This device is certified for about 4 years. Of course, we did the preclinical experiments. We treated which confirmed what I said before, namely you have a better repetition of the drug within the abdominal cavity, and also a better penetration into the tissue, and this in a significant amount. So it looks not only in percentage, but it's a factor, and perhaps even an order of magnitude.
You demonstrate on human that the principle is okay and functions. For what sort of disease, what sort of peritoneal carcinomatosis did you test that? And what are your first results? Because I know that you start a phase 2 trial. So for which disease and what are the first results?
So the first in-human application was November 5th, 2011, so it's not a long time ago. In the meantime, we have about 700 applications, most of them at the beginning within the framework of a off-label use program, which was approved by the International Review Board and by the German Federal Drug Authority. Then we started with prospective clinical studies. We just closed the first one in ovarian cancer, showing promising results with high clinical benefit rate of 60% in the platinum-resistant recurrent ovarian cancer in the third-line situation, which appears very promising. Histologically, we even had a remission rate of around 80%, which confirms the pharmacologic advantages of the technique, and which probably to be explained by the high local dose of the drug we can apply into the tumor node. The safety data of this study are also very good. There is no mortality, no grade 4 CTCI adverse event, and 15% grade 3 adverse event, which appears to be very favorable compared to the numbers reported after systemic chemotherapy in this situation. So obviously PIPAC is well tolerated by the patients. There is another study ongoing on gastric cancer, the PIPAC-GR1 study, which already recruited about 1/3 of the patients, so which is recruiting rapidly. We now just start a doses finding study in ovarian cancer, because this has been asked for by the regulatory authority, and we expect to start the first prospective randomized trial in the second half of 2015 or at the very beginning of 2016.
Okay, so a new concept, a new device, and a new things for peritoneal disease to treat, not an opposition with the other technique, with surgery on IPEC, but a new way to help people. That's right?
Yes, well, to make it short, we have the impression to sit in a new car with 500 PS and we still don't know how to drive it.
Okay, wonderful. Thank you very much.